Yeah, so I'm Dr. Pack. Nice to meet you. Kind of a little history on me. I was actually a patient of Dr. Hornick's when I was a child. So I started out at this practice when I was about 4 years old, and he kind of inspired me to do this. And then when he wanted to retire, he brought me back to take over. So it's kind of a full circle journey for me, and that end of things. Um, so fun to be with you today and kind of go over some stuff, uh, on the fiber. I'm going to try to make it kind of short on my side. I'm going to hit a couple major points. I got it broken into three kind of quick categories just to kind of give you a little bit of a thought about fibro medications in the eye, in and of itself. And then really, I'm just going to kind of open it up. If you guys have questions or thoughts, I can kind of, answer some things from there. I could get into my history. I've got a long history of things, but I'll save the time for you guys to kind of go on this thing. So you'll basically, when you look at it, and you guys know this one, but fibromyalgia really is characterized by a widespread, pain throughout the body from inflammation, stemming into the nervous system and the nerves in the body itself. Break it down into medications that are used to kind of help treat or alleviate these pains and these symptoms. And we have it kind of broken into basically four classes that we kind of go with. You have your SSRIs, your NSAIDs, nerve pain medications, and as well as muscle relaxants. So I'm going to kind of go into each one because each one carries a lot of side effects that could potentially affect your eyes and vision. And I'll kind of hit a little bit on each class and what they can do, to you. And you'll see a theme here as we kind of go through this. But we'll start with the SSRIs. So SSRIs, the big ones in terms of visual and biggest side effect they have is blurred vision. So they really mess with the actual vision itself in the eye. They do have a high propensity for causing dry eye, which most medications will do, on that end of it. In a severe case of that, you can actually, SSRIs can actually cause a form of acute angle closure glaucoma, which means that the angle that drains the fluid from the eye closes, causing a large spike in pressure and vision loss, on that side of things. NSAIDs, which, traditionally naproxen is the big one, that they would prescribe for this. Mostly blurred vision, especially in your reading points, at the close point. It really affects that because it really messes with your pupillary control, your ability to switch focus from near to far in terms of things. The nerve pain medications, mainly your gabapentins, pregabalins, again, blurred vision, on that one. The big one with those, though, too, is they can cause double vision. So they can cause you to lose muscular control because of that nerve, block where you can't innervate the nerves and the muscles to hold the eyes in points. You can actually start to see double in that. And again, that one has a severity case where we can get, permanent visual field defects, with, prolonged use of the medication. The last group is your muscle relaxants. Again, the big one is blurred vision. They all affect that. Double vision, again, on the muscle relaxants, because again, if they're affecting the muscular response, you can't hold the eyes on image together, focusing issues, and again, dryness. So the big kind of hallmark with any of these, you look at it, is we're focusing on it affects muscular response, it affects dryness, which is
Also,
triggered by nerve response. And then obviously it affects your overall vision, in that end of things. Um, the big ones when you look at the eye. So, if you're looking at just breaking fibromyalgia into the eye, what are the big things that we're looking for when you're here, or the big things that we deal with your when you're in the office to kind of look at. I'm going to break them down and I'll kind of make a little comment about each. And again, you guys can focus on questions here afterwards. But the number one really kind of comes into dry eye. On these, a lot of it's medication induced, in terms of, the major side effect of a lot of medications is dryness. But the other part too with it is just the inflammation. You get inflammation in the tissues, you get inflammation in the nerves, which then leads to poor tear productions, as well as an ineffective tearing reflex, for things. So you're just not producing good quality tears or enough tears at all, that are there, to kind of help with things. The Next one will be blurred vision. So again, blurred vision is a side effect of most medications, right? The second thing you look at with blurred vision is you're going to get a lot of pupillary adjustment and pupillary effects from those medications, and during that process, which is kind of what messes with it. So the dryness and the pupillary effects and the muscular effects all can affect the clarity of the vision, there. Um, moving on, when you look at it, pain, obviously that's the hallmark of this disease. You're going to get it. It's basically inflammatory driven throughout that end. Inflammation can cause a lot of different pains in the eyes, from light sensitivity to dull aches to sharp pains. As it is, because essentially your eye is just a giant ball of nerves. And then that end of things. Um, in those ones, we have specific treatments, that we kind of look at, for them. And you may be on some of these may be new to you. We can kind of go over that. And I'll kind of hit the treatments for those three, right now. And then I'm going to talk a little bit about the two most severe, kind of things that can be brought in with fibro at the end here. But dryness itself, really, we start with over-the-counter stuff. So over-the-counter artificial tear supplements, they come in different varieties. They can be used. The unfortunate part with over-the-counter tears is they are kind of highly ineffective in most cases, because you got to use them a lot, to get that kind of effect to kind of do. Usually in office now, we're going to start you out either on like a prescription Tyrvaya, which is a nasal spray, or a Stasis, or even a Mibo, RX, which is a newer treatment in there. We do have in-office treatments now with IPLs or intense pulse lights, which can be effective in the office, or RF frequency treatments in there. The catch with those is they're more limited in access and not covered by insurance, and cost can be a concern with that, end of it. Blurred vision, not a whole lot, that can be done, in terms of, you got to be on the medication for a reason. Can't get you off the medication. Really, we look at that with adjusting working distance, lighting, size of fonts, prescriptions and glasses, contacts to help kind of sharpen what we can sharpen, in there. Muscular side of things, we can look at, we do prismatics, neural lenses. There's some contrast lenses like Raptor lenses and Avalux lenses, which, are designed more specifically for other conditions, but can help with those kind of things as well. In pain, it's really just treating the inflammation. Yes, you're treating topical steroids, you're treating with NSAIDs, you're doing what you can, to kind of, control the inflammation, to try to dull that response throughout the eye itself. The two big ones, though, these are the two big ones that, are kind of more on that severe side of things, is fibromyalgia can run concomitantly with Sjorgen's syndrome. So a Sjorgen syndrome has kind of a triad. It's a hallmark triad of things, which leads to a dry eye, a dry mouth, and a dry nose, on that side of things. So lots of dryness. And a lot of it is indicated and hit because of inflammation of the nerve paths, deadens that nerve response to moisten these tissues, throughout that end of things. Sjorgen's is an easy diagnosis in the sense that if you think you have it, or you have one or two of those, kind of things, we can do a quick blood draw, determine if you carry the marker for it. It's semi-autoimmune in some sense. But for my side of the coin, once we have a definitive Sjorgen's, we really look to treat the dry eye with, steroids, or with some type of, prescription, treatment for dryness itself on that side of things. The biggest one, and this is the most severe one, is, because we're talking about nerve tissue, we're talking about inflammation, with fibromyalgia, you can get incidents of optic neuritis. So an optic neuritis is an inflammation of the actual optic nerve itself. Now, those are severe, urgent conditions. And the fact that if left untreated, you can lose your sight permanently. Because you think of it, your optic nerve, it's kind of like the HDMI cable that plugs you into the brain. So if that cable gets damaged, whatever your eye takes in, you can't send out. So those are urgent conditions that we kind of point out in these cases, that if we're getting any sudden change to the vision, and we're not talking about it's a little fuzzy today, we're talking about I can't see things, or I got black spots, or it's just something's really off. You need to get in right away. We need to see it. We need to confirm it with some ultrasound scans or looks at the nerve itself, because you're going to be put either on IV steroids, right away to kind of get that down, or we may have to even look at doing a decompression surgery, where they do a surgery around the optic nerve to relieve inflammation, around that aspect of things. So go anywhere from nuisance, from blurred vision nuisance or dry eye nuisance, to pain, to vision loss, in that sense. So I don't envy any of you, on that side of things, but we're always here to help, on that end. But that's kind of the breakdown that I kind of went through today for you guys, on fibro in the eye and medications and things. Feel free. I mean, at this point, I would say, he kind of clued me in to say that you guys like to ask questions on things, so I'm going to kind of just leave it open for questions on stuff, and I'll kind of try to answer the best I can from that point of things for you.
Uh,
Um, oh, go ahead.
oh no, that's fine. You can go first, Mary Lou.
I do have Sjogren's, and I have the dysfunction of the ovarian gland, and I just wondered, how would you treat that, or can you give me any insights? I'm sure you do have some on that.
So, um, you know, again with the Sjogren syndrome, it's a lot of kind of uh, trial and error. Each patient's different, each case is different, response to treatments is different with each one, on that end. Usually with the Sjogren's patient, I skip anything over the counter because it's usually very ineffective, in that end of things, or we have to use it so much that it's hard to maintain. And we're usually on that one, we're looking at trying to get you into something along the lines of either like a Restasis or a Xiidra, which have light anti-inflammatory properties, but will also cause, increased tear production. A lot of times those all pulse dose of steroid in for, a 7-day period or a 10-day period from time to time to reduce overall inflammation, on that end of things. We've had really good success with Sjogren's in the newer RX, which is Mibo in there. Mibo is a very unique compound. I call it Rain-X for the eyes, essentially creates this impermeable layer that kind of coats the surface so that it doesn't dry as easily and as quickly in that end of things. Some of my colleagues are very, very high on using IPL treatments, so intense pulse light around the eye to stimulate, reduce inflammation in the dermal tissue, reduce inflammation in the ocular tissue, increase, oil flow through the glands, on that side of it. The big thing with IPL is, it's a large cost to the patient. It has to be repeated frequently, on that side of it. It doesn't come without side effects, in terms of things. So, but usually with me, like I said, I'm going to start with some type of prescription. We're going to try one, see how it does, and keep following and trying until we get the right mix or cocktail for what works for that patient on that time.
Would you say that is that what's causing my meibomian gland? Is the
Your
um
meibomian gland dysfunction?
yeah.
So very possibly, so usually with the meibomian gland issues, we all have them, in that sense, so if we live long enough, we all have them because those glands just atrophy throughout our life. So they don't secrete as effectively, as we mature. The thing we know with meibomian gland issues is it's inflammation. So if you have inflammation in the tissues, that gland, which is narrow, gets inflamed, it pinches it off and causes poor oil secretion production. So it's not directly related to the Sjogren's, but it actually intensifies the effect of the back end of it because we use that oil from the meibomian gland to prevent evaporation of the tears, in that sense of things. So, again, so meibomian gland issue, the Mibo is kind of in that drop thing because it's giving that kind of coat to replace what you're not getting from the oil side of things. The IPLs are really good at, trying to reopen that meibomian gland aspect on it. We've had success on some in-office stuff with it, a lighter in-office stuff with it. And those are out there too. And we try to, make it affordable for everybody to do. But, the hallmark with some of the meibomian stuff was heating. So you heat um, the face or the eyes, with a mask or device. There's a specified temperature for a specified time, which has been studied to be the best. And what it does is it liquefies the oil or the meibum in there, and then you express it in the office or you squeeze it out, essentially to get that gland reproducing and removing in and of itself. So there's multiple devices on the market to do that. The main hallmark one is the IPL nowadays. Um, we do it in office, and Dr. Hordick did it. I do it. We have heat masks in the office that time out to that right temperature, so we warm it up, and then we use a local anesthetic in a manual expression in the office, which is the traditional way to kind of do that stuff. Now there is, and this is unrelated to both the fibro and the Sjogren's, in that sense, but there is some new data coming out with a different treatment called XDEMVY. XDEMVY is a tighter dose drop to help bring a mite that lives naturally on our skin back into normal population called Demodex, on that side of things. So Demodex is a nocturnal mite that lives on our skin and actually eats oil. So what happens is during the day, they actually crawl into your meibomian glands and live there because they got a rapid food source. The problem is as we age, they get higher concentration. Sometimes just life gets them in higher concentration, and we have to bring them back into mode. So we never had a great treatment for them. The XDEMVY came out a couple of years ago. It works very well at bringing that into play. But some of the newer studies are showing that we're seeing reversals in some of the meibomian gland dysfunction issues when the people are on the XDEMVY as well. So that's another one that we can kind of maybe link in possibly to help with that over time.
Well, I don't want to take too much of the time because other people want to ask questions, but I think I have the meibomian gland thing and blepharitis because I have rosacea.
Mm-hmm.
So I've heard that there's a connection.
Yep, it's all that. So rosacea's dermal inflammation, which is actually linked to meibomian gland issues, and they're
Right.
finding out in the research now that rosacea and meibomian gland issues may actually all be driven to Demodex issues to start with. That they're finding that the rosacea may actually be a Demodex issue, not so much an inflammation issue. So they're kind of like tying it all back together, thinking that that may be the start of the process for everybody and that. So you're going to start to see more and more directed treatments toward that, especially in some of those ends, because some of the rosacea treatments, if you're on them long term, they can actually build antibiotic resistance, because you're giving you low dose, antibiotics in some of those treatments. And it's not good for long term, really use for other things. So, but
okay.
yeah.
Thank you.
Yeah, no worries.
I just had a couple questions,
Yeah.
Doctor. First of all, are there any more eye drop recalls, and is it safe to use Blink Tears and Terra Tears? Because that's what I use often.
So Blink and Thera have not been linked to anything at this point, on that end of stuff. Now, what I would tell you is most of the eye drop recalls that are out there came from foreign-based drops. So that the big thing we tend to kind of consult patients with is try to stay with your name brands, try to stay away from your generics, if you can. The two big ones that were linked, and it wasn't just the over-the-counter tiers, it was actually for some of the prescription stuff too that got it. They were mostly sold at Walmart's and Walgreens, I think it was, and it was all from a pharma tech company out of India, that had quality control issues. Because we had some actual like generic medications that were recalled because of the same thing, on that end of stuff. So usually if you stay with your name brand stuff, it's generally pretty safe, in that end of the coin. And they're quick to pull it sometimes too. If there's not a name brand issue, they're more quick to pull it, off the market, on that side of things. But we haven't had anything new since the last one that struck on that generic based artificial tear stuff. So
that's good to hear. I just had one last question, and then the rest of the members can ask. What age do women start having cataracts? I'm just asking for my mom and other people that are older in age.
The answer is going to depend on where you live, somewhat.
Okay.
How's that sound? So a base cataract, so the garden variety cataract that we all get throughout life, we call it the death and taxes of the eyeball here, is a function of your lens in your eyes to absorb ultraviolet light out of the atmosphere. So it protects your retinal tissues, which cannot take the high dose of UV. So basically, the longer you live, the more UV you absorb, the more you develop cataract, in that sense. So the way we describe it to patients is if you were to take a clear piece of plastic and leave it out in the sun too long, it discolors. The same thing happens with your eye, in the cataract sense. Now, because it's UV driven on that garden variety or the age related form, if you spend your life in the north here, where we are, that northern based equatorial UV index is very low. So cataracts for us up here in the Michigan area, 70s, 80s, if you're early, maybe late 60s is when they start kind of really rank their heads. Now, when I was doing mission work and I was in sub-Saharan Africa and Central America, Southeast Asia, when you're in those equatorial ranges, 30s and 40s, cataracts, on that side of it, because they're in that full intense UV, no access to sunglasses, hits them hard, that end of things. So it is kind of a little bit of a population demographic where you're at. Now, on the flip side of things, though, there's a health component to it. So the more issues you have, especially diabetes, inflammation issues, the more medications you're on, steroids, and things like that, those all accelerate that process. So that is that kind of wild card in there that, if you have a lot of health issues going on, that cataracts can come earlier, because of side effects from medications, inflammation in the body, other issues that kind of come in play. So there's a lot of variability in it, but usually what I tell people up here is, if we have a relatively decent health, and you live in Michigan, late 60s, early 70s, about when we're going to start talking about that stuff for you.
Well, thank you very much, Doctor.
Yeah.
I have a couple of questions, Doctor. I do have extremely dry eyes, and my ophthalmologist doesn't really want to start me on the prescription eye drops.
Okay. Yep.
And I heard you say that the over-the-counter ones are largely ineffective.
Yep.
And I believe that's true because, he tells me just use more, use them as often as you need to, but it doesn't really seem to help me that much.
Yep.
And, if I use them several times a day, it doesn't seem to make a big difference.
Right.
It bothers me to the point where, it's hard for me to read anymore. Look at the computer. It seems like my eyeballs just try to, get out of my head. They just ache. It's very difficult. I also have blurry vision sometimes, just slightly blurry. So I'm not quite sure if it's related to the fibromyalgia or if it's just dry eye. I remember a few years ago, my ENT doctor told me that I can't remember what he called it, but it was to do with my salivary glands.
Yeah.
And he told me to suck on like sour candy to increase my saliva and that kind of thing. So I've never been diagnosed with Sojourn's.
Yep. So you may have it, then, it would be something you could talk about having a blood screening ran for it, because it's a marker in the blood. Because again, mouth, dry eyes, dry nose are the hallmarks, of that kind of thing. And again, it is kind of concomitant with the fibro, aspect of things. Now, the blurred vision you're getting is probably related to some of the severe dryness, in some sense, in that end. You'll quick kind of see on that one, kind of rule that out. It's not a prescription thing or some other thing. Is, if you're trying to read and it's fuzzy, add a drop or two of your liquid tears, blink, and then try again, and see if it helps. If that helps, then we know it's some dryness issues in there. Yeah, the hard part over the counters, is you go out there, there's a billion of them. So there's water-based ones, there's oil-based ones, there's combo ones, there's gel ones. It's like, which one do you grab? So there's certain ones are better than others. Certain ones last longer than others. In that sense, certain ones actually make your vision blurry, which is kind of a funny thing, but they do. So you got to kind of clue in on the right one, for that end. Now the catch with it is some people, they may need to use it, 10, 11, 12 times a day to get relief.
And it's safe to use it that often?
And, if you do the non-preserved ones, which are the single vials where you pop the
that's
top,
what I use.
Yes, you're fine. If you're using the one in the bottle, you got to watch it, because the preservative then can become an issue, on that side of things. But that's the thing with it. It's, who can keep up with 10 or 11 or 12 times a day, on those kind of things. Now, what we tend to do, or what I kind of give is I use my cheat code, I call it, for dryness. If we're going to try to do over the counters, and see if we can get effectiveness with this. Usually what I have my patients do is I tell them take a 30-day span of time, take your artificial tears, stick them in the fridge and get them cold, and then what I'd have you do is for week 1, you're going to dose it 4 times a day. Week 2, you're going to dose it 3 times a day. Week 3, 2 times. Week 4, 1 time. So you're going to start with a bunch and ramp yourself off of it. And the thought with that is if we supplement the gap in tears a lot at the beginning, and we use the cold chill to kind of start to naturally reduce some of the inflammation in the eye, because they're always side to side, then maybe we can get your tears to kind of rebuild and do some of the work yourself. And then usually what I say is if you get to a month and you stop and you get dry again, go backwards, add a drop on. and see if it helps, and to see if it solves it. If it doesn't, go to 2, go to 3, and then see where you end up. And if we end up going back all the way up to 4 or more, then I tell them that's time where we need to talk about that prescription for sure
Okay.
because of that. Because the hard part of the prescription sometimes, especially the way the pharmaceutics work this in the world nowadays, is anything to do with dry eye, it requires a PA process and it requires record submissions and it requires me to make a case why you need it and why we tried other things to do it. And even then, when they get approved, sometimes it comes back and the cost is like, well, crud, I don't know if I want to pay that, on some of them. So it's kind of like it's that balance of it. So I get some patients that they're like, yeah, let's do it, and we prescribe it, and they get approved, and they're still paying a couple $100 for it out of pocket.
Wow.
And they're like, well, I can't do that, and then we
Yeah.
have to try to get creative with some of those things too. So,
Does fish oil help? Does fish oil help?
Depends who you ask. How's that sound? So the belief was always that if you used fish oils, and you got to look for a fish oil, a good fish oil too is the thing. So you flip the label, it's 900 milligrams of EPA DHA has to be present inside of the dose, on it. And you got to be careful with that because I've looked at it before sometimes with these in they'll say on the back, 2 tabs a day. And then if I try to get my 900 on some of those ones that say 2 tabs a day, it's like 10 tabs a day to get there, to get the actual recommended dosage. So the original study showed if you're at 900 milligrams of EPA DHA, it caused reduced inflammation, it caused increased vascular flow, and it actually helped with meibomian gland dysfunction stuff. Those were the original studies. Now a couple of years ago, there were studies that came out that said that fish oil did nothing for cardiovascular, it did nothing for dry eye. So then it's kind of like, which one's the one? Which is the one that's kind of the real reason here, in that. So we've always held to, we're very big, Dr. Borda was very big into it. I'm very big into supplementation and natural kind of stuff as well. There's nothing wrong with fish, in that sense. Fish oil is good. Flaxseed oil is another good way to kind of get it. Vitamin E is another way to kind of look at it. We're big into all those to kind of help with these things. We definitely think it works and it definitely helps in those cases. You just got to be careful when you get it because they're not all created equal. And that
Okay.
So you got to kind of watch those labels sometimes. So.
Okay. One more comment.
Yep.
I have had cataract surgery. It was back in 2018.
Yep.
And this is nothing negative about my doctor. I think it's just related to my overall fibromyalgia. My body does weird things that doesn't happen to other people. But I had the surgery, and supposedly after you have the cataract surgery, you only need glasses for reading and not for distance. Well, mine turned out pretty much the opposite, where I didn't need it for reading, but still kind of needed a lighter prescription for distance.
Yep.
And then since I do still wear glasses, it seems like my vision is almost kind of getting worse again, where at first I didn't totally have to depend on them. I'm back to the point where I have to depend on my glasses.
Yeah.
Have you ever seen anything like that?
Yeah, it happens. And there's more variables with you, in that sense. So sometimes it's just a bad reading. So it's when they do the reading to calculate the implant that they're putting in your eye to correct your vision. Sometimes the measurement goes funky, on that side of it. So one of the big ones that skews the measurement to cause those things is dry eyes. So the eye's super dry and they're not balancing the dryness before they take the reading. The implant they're putting in is not the right power, so it leaves the residual prescription.
Okay.
The other one sometimes comes in, especially when you're in a condition where you have inflammation or you have other things that are going on. Post-surgical swelling and inflammation. So again, when they do the cataract surgery, they make an incision in your eye. They don't suture it because if they do, then they're going to induce a prescription because they're tightening naturally on the eye. So they leave their natural pressure eye to hold the wound closed while it scars and heals. Now, if you have inflammation, that scarring and healing is going to be more intense or more of that, and that can distort and induce prescription change post-fact. So even if the implant is great, if you're at a high propensity for inflammation, you tend to have more chance that you're going to end up with prescriptions afterwards. So it happens. It's rare. kind of hate when my surgeons say you're not going to need glasses afterwards because it sets them up for failure if it doesn't go right,
Mm-hmm.
in that sense. And I will say the funniest one that I'll tell you is my grandma, she had hers done. She hung on to it to the end. Is she would tell me all the time. She'd say, "My surgeon told me I didn't need glasses. When I got done my surgery, I could throw my glasses away and I'd be all good." And to the end of her life, she would wear her glasses. She couldn't see anything because she ended up with a large prescription afterwards. But he told her, so
Right.
she
Mm-hmm.
wouldn't wear them, and she would only put them on when she really wanted to see something. And so I've always had kind of like, don't tell them that. Just tell them we're going to make it better. You know.
Mm-hmm.
But
In addition to being dry, and I don't know if they probably go hand in hand, my eyes are very sensitive.
yep,
I always have to have on sunglasses if there's at least a little bit of sun out, or sometimes
yep.
even when it's not. Bright lights, even in my house.
Mhm.
I can't stand the bright lights or
Yep.
anything. They're
So
extremely sensitive. Is that
cat,
part of dry
cataract
eye?
surgery, cataract surgery will do that for one because you don't have a way to naturally filter light coming in your eye anymore because again your lens is gone, so it
Mm-hmm.
intensifies light, on that. So most cataract patients will be more light sensitive afterwards. But if you mix in the other two, you have inflammation throughout your body. Inflammation causes light sensitivity in the eye. That's kind of the hallmark for light, the inflammation in the eyes. If we have so much light sensitivity, we know they have inflammation. We just have to figure out why, on that end. And then dryness too. If your eye's dry,
Mm-hmm.
it's going to
Okay.
scatter light differently and cause more disruption. So if the cataract's done, we control the dryness the best we can. The inflammation's the outlier in that sense. Sometimes with those, if we get severe light sensitivity, that's where we start to put in, tints or dye injection lenses.
Hmm.
Sometimes. So sometimes we'll put a light tint in the lens, to kind of help with that. If it's severe, then we can do a dye injected lens, a very specialized dye injected lens. They're actually studied for migraines, light induced
Hmm.
migraines, but it works as well for those.
Okay.
So
Oh,
yeah.
Okay.
sorry to
Thank
interrupt
you.
everybody. I just want to let everybody know we're down to less than 1 minute before we get kicked out of the first
Okay.
Zoom. Did you have
Logging
enough?
out.
Yeah, we're gonna go into the number two. Did you have time to finish up your talk in number two, Dr. Pack?
I can give you guys maybe like another 10 minutes.
Okay, sounds
Yeah.
good.
And then I got to get fixed up for the afternoon.
All right, so we'll meet each other in Zoom number two.
All right. Sounds good.
Yep, see you soon.